Good morning, everyone. Good morning, and welcome to another NCLEX review. My name is Alexandra, and it is a blessing and a pleasure to have you here with me. Today, we are going to do adult gastrointestinal. So, please make sure that you are keeping up with the recordings, making sure that you're either coming to class and taking notes, or that if you miss class that you're watching the recordings. As you know, the recordings are sent to you in the WhatsApp group. Okay, and what is important is after class, make sure that you either go over the recording again or at least go over your notes again. It's very important that you stay active in this. And after you review the recording and your notes, you do questions in your own private Q bank that line up with what the system that we reviewed. So for example, last week we did renal. So you should have gone over the recording, gone over your notes, and then done questions on renal. The more questions you do every day or every week, the better. And remember, even if you put 10 minutes in a day, even if you put 20 minutes a day, that still matters. So don't feel like, oh, I can't study today because I don't have 4 hours to study. You don't need 4 hours to study. If you have the 4 hours, that's great. But you do what you can when you can. And remember, when you can't run, walk. When you can't walk, try to get up and do the best you can. Okay? And another thing that always keeps me motivated is do it. Do it tired. Do it crying. Do it if you're depressed. Do it if you're sad. Do it if you're confused. But just do it. Just do it. Open the recording and just listen to it for a little bit. Open the recording and go over your notes. Go over your notes. Do 5 questions. Anything, but just do it, and you keep doing it until you achieve your goal. You can do this, and I know that God will help you. All right, so let's get started. So we are in adult GI. So we're going to hit the basics. What is important for you to know so that you can pass this NCLEX, right? So the basic anatomy of the gastrointestinal system. So the digestive system, also called the gastrointestinal system, includes everything from the mouth to the anus. So your mouth, your salivary glands, your pharynx, which is your throat, your esophagus, your stomach, your liver, your pancreas and gallbladder, your small intestine, large intestine, rectum, and anus. That is all part of the digestive system. Even technically, the teeth and tongue are part of the digestive system because they help to break the food down. So here is another picture that's very helpful for you to see, especially when we are going to learn about GERD or gastric esophageal reflux disease. And so this is going to help you to see that when we swallow food and it goes down the esophagus, the goal of the gastrointestinal system is to get food from the esophagus into the stomach so the stomach can use its acid, which is called hydrochloric acid, to begin breaking the food down. And it's important for you to know that the stomach has 2 important sphincters, the lower esophageal sphincter, and then another one we're going to see later on in pediatrics, especially the pyloric sphincter. So it's very important to know that When we swallow food and it goes down the esophagus, the lower esophageal sphincter has to open so that food can come in. And once the food is in the lower esophageal sphincter, or the LES, it has to close. It has to close so that food and acid does not go back into the esophagus. So when someone has a weak or incompetent lower esophageal sphincter, this is what leads to GERD, or acid reflux. When this doesn't close all the way, food and acid are going to regurgitate back and irritate the esophagus. And not only is GERD uncomfortable, but it's very damaging to the esophagus because the acid can erode or eat away at the esophagus, and it can even lead to changes in the cells in the tissues of the esophagus, which can lead to a type of cancer called Barrett's esophagus. So that's why we want to avoid GERD. And when someone has the symptoms, we want to give them the proper education so they avoid highly acidic foods and take the medications like the proton pump inhibitors to help avoid complications. Okay. Also, there's an upper esophageal sphincter. So you have an upper esophageal sphincter that has to open and let food down. You have a lower esophageal sphincter to open and let food into the stomach and close so that food and acid does not regurgitate. And then you have a pyloric sphincter, which we will talk about more when we get to peds. And here's the pyloric sphincter, okay? Then we have the different parts of the small intestine. So after food exits the stomach and passes the pyloric sphincter, it enters the first part of the small intestine, which is called the duodenum. Then from there, while it's in the duodenum, and we can't see it yet, but we're going to see it in a little bit in another picture, but when food enters the duodenum, bile is going to enter the common bile duct and squirt bile into the food contents that are in the duodenum now. And this is what's going to help break the fats down. So the liver makes bile, the liver makes bile, and it's stored in the gallbladder. And from the gallbladder, it will leave the cystic duct and enter the common bile duct, and it will squirt into the duodenum, okay? Also, the pancreatic duct is going to release hormones such as lipase. So bile and lipase are going to help break down fats. When you're chewing food in your mouth, other hormones and components are going to be released that will also break down sugars. So your body really is well designed to help you to break down food so that you can get the nutrients from the food. That's the whole reason we eat. I know that eating is a very pleasant experience, but the whole reason that we eat is so that we can obtain the nutrients. And your gastrointestinal system is well designed and well trained and well structured to obtain as much nutrients from your food as possible. So from the stomach to the duodenum, the food will then enter the second part of the small intestine, which is called the jejunum. From there, food will enter the ileum. So I remember it as DJ Ili. DJ Ili, that's the order of the small intestine: duodenum, jejunum, ileum. So if somebody has a jejunostomy, right, you know that there is a hole in their jejunum and fecal matter is leaving through their jejunum. If somebody has an ileostomy, there is a hole in their ileum that a surgeon created and the poop is leaving through the ileum. And then we have the colon. We have the ascending colon, we have the transverse colon, and the descending colon, and then the rectum. So if somebody has a colostomy, the surgeon has made a hole in the colon and the fecal matter is exiting that way. So we just went over the large intestine, but there's just a few more parts. Okay, so we already know ascending, transverse, and descending. So that's the order of how fecal matter, because once food enters the large intestine, okay, so let's go backwards just a little bit. So when food enters the stomach is going to begin churning the food, and it's going to use hydrochloric acid to also help break the food down. And so this digested material is then going to enter the small intestine. And the goal of this is the small intestine has microvilli on its cells. And the goal of the small intestine is to obtain all the nutrients from the food, all of the nutrients. So this is where your body is going to get the nutrients and vitamins it needs to keep you alive. Then it's going to enter into the colon. And when food matter enters the colon, the nutrients are all gone. And it's almost a sort of like a paste. And really, this is where we're going to take the water out. Okay. And so there's some other little, so this is the end of the ileum. You see, this is the end of the ileum from the small intestine, and it's going to connect with the first part of the colon, which is called the cecum. Okay, so the ileum, okay, and I know it doesn't show it that well in this picture, but it's going to connect, the ileum is going to connect with the first part of the large intestine, the cecum. And so there's a very important valve here called the ileocecal valve. So this connects the last part of the small intestine, the ileum, with the first part of the large intestine, the cecum. The ileocecal valve, we are going to talk about that again in peds. So make sure you have learned this. Also, there's the appendix, which has no real function. We don't know why it's there. God knows. But the only issue is when it becomes inflamed, which is appendicitis, or when it ruptures, which is called a ruptured appendix. Appendicitis is very painful. A ruptured appendix is very dangerous because a ruptured appendix can lead to peritonitis and sepsis and death because it causes fecal matter to enter into what should be the sterile peritoneal cavity. Your peritoneal cavity should be sterile, right? And what's inside the intestines is not necessarily sterile, but the cavity that holds the organs should be sterile. And so when the appendix ruptures, fecal matter that's inside the colon enters this sterile peritoneal cavity and can lead to not only a lot of, it can lead to a serious infection. Okay, so just remember that appendicitis is extremely painful. A ruptured appendix is extremely dangerous. Okay, so we talked about the cecum, we talked about the appendix. You know the rectum, that's where the poop is stored before we defecate through the anus. So we already reviewed this picture. Okay, and this is just a little bit more of a closer up view of the different components of how the liver, it makes the bile and sends it to the gallbladder to store it, and how bile will leave the common bile duct, and pancreatic enzymes will leave the pancreatic duct and through the ampulla of Vater enter in through the duodenum and secrete those substances into the food matter that is passing through. Isn't it amazing how your body knows when to release those substances? Now, that's something to think about. I think God did a really good job in designing the body. Next up is you have to know your quadrants, and you have to know what is in the quadrants, okay? So you definitely have to know this for your NCLEX. So you have your right upper quadrant, left upper quadrant, right and lower left quadrant, okay? So you have to know them. And so just understanding what organs are in what will help you, okay? So let's see something here. So write this down and memorize it, because if a patient is complaining of pain in these areas or regions, you want to know what is there so it can kind of guide you to what could be the problem. And I also included something from the abdominal regions. So one of the regions is epigastric. And so I just want you to quickly be able to identify that. So right upper quadrant, that's where your liver or gallbladder is. So if your patient comes in complaining of right upper quadrant pain, or they have an enlargement there or swelling there, when you begin palpating or it's distended, you are going to think, is there something wrong with their liver or gallbladder? Okay. Left upper quadrant pain, that's where your stomach and pancreas are. Epigastric region, that's where your pancreas is. And also write down, that's also where heartburn can happen too. So on NCLEX, if it says the patient is complaining of epigastric pain, you can think pancreas and maybe acid reflux. And right lower quadrant, that's definitely appendix. Okay. And finally, left lower quadrant, that's where a part of your colon is, the large intestine. So we're going to learn about diverticulitis and diverticulosis in the end of this chapter. And so that is definitely something to know. So make sure you know the difference of what could it mean if a patient has right lower quadrant pain versus left lower quadrant pain. So if a patient has right lower quadrant pain, it's more likely going to be appendicitis. If they have left lower quadrant pain, that's more associated with the large intestine, which could be like diverticulitis or diverticulosis. And we're going to learn the difference towards the end of the chapter. All right. And remember, this is recorded, and I always recommend that you go back and you watch the recording again. Okay, so now we're going to talk about some important GI diagnostic tests that you have to know for the NCLEX. So please write these down, or it's in the recording, okay? But you have to know these. You have to know what is an upper GI endoscopy, which is called the EGD, okay? You have to know what is a lower GI endoscopy, which is called a colonoscopy. You have to know what is a laparoscopy, what is an endoscopic retrograde cholangiopancreography, an ERCP, a paracentesis, and a liver biopsy. So all of these tests, you have to know what they are and your nursing interventions and considerations for them. All right, so we're going to switch over to the study guide. And so the gastrointestinal section is from pages 220 to 232. Okay, so write that down. So 220 to 232. Okay, and that's going to be your homework to read that. Okay, so from 220 to 232. So we've already went over the different components of the gastrointestinal system. We also went over the different components of what is called the hepatobiliary system. So the hepatobiliary system is still part of the GI system, but it's more like an accessory to it. But these organs, the liver, the gallbladder, they're still very important components of the GI system. So we've went over these. And now we're here for diagnostic procedures. Okay, so upper gastrointestinal endoscopy. Okay, so esophagogastroduodenoscopy. So this is what we call an upper GI endoscopy. So the patient is sedated and an endoscope, which is a long tube with a camera, will be passed down the esophagus to look at the gastric wall, the sphincters, and the duodenum. Tissue samples can also be collected. So the goal of an upper GI endoscopy is to insert a camera inside the patient's mouth and look at the esophagus, the stomach, and the duodenum. So that's why it's called an EGD, esophagus, the gastric, which is the stomach, and the duodenum, which is the first part of the small intestine. And the patient is put under conscious sedation. So conscious sedation means that they'll be able to talk to you. They won't remember anything. They won't really feel any pain at all. Okay? So nursing considerations and interventions. So this is invasive. So whenever you're putting something inside the patient, you need an informed consent. Due to sedation, the patient must be NPO prior to the procedure to prevent aspiration. Monitor and maintain a patent airway and monitor the O2 saturation. So if you are assisting the healthcare provider with this procedure, the number one goal is to make sure that the patient doesn't vomit or choke up anything, because then those components can go down the trachea and the patient aspirate. So that's why we don't want anything in the stomach when we do this, and that's why the patient is going to be NPO, okay? And that's why we're monitoring the O2 saturation, so that if we need to perform an emergency intubation or provide airway support, we can do that. Now, after the procedure, your major nursing priorities are going to be to assess airway, making sure that the airway is patent, because they went through their mouth to do this. And remember, they received sedation, and sedation is always going to somehow affect the patient's ability to protect their airway. So that's why airway is your number one priority. Monitor for any signs of perforation. The camera, it's very rare, but it could have punctured an organ or tissue. So looking if the patient is vomiting up blood or coughing up blood, you would definitely want to make sure that the O2 saturation is stable, and you would alert the healthcare provider immediately, and we may have to perform an emergency intubation, and they go back toward the procedure so that the healthcare provider can identify the bleed and stop it. Gag reflex. So usually after this procedure, the patient is going to be put on a diet order of NPO advanced as tolerated, or advanced as tolerated. And so what that means is, don't give them anything to eat or drink until their gag reflex returns. So write that down. NPO advanced as tolerated means don't give them anything to eat or drink until their gag reflex returns. And how do you know their gag reflex has returned? You give them a small sip of water, and if the patient can swallow it without coughing, their gag reflex has returned. Now, if you give them a small sip of water and they start coughing and turning red and their O2 saturation drops, do you think we should advance the diet? Tell me in the chat. Exactly. Very good. So if we give them something to drink and we're not going to start with, food. We're going to start with a liquid, just a small sip. And as long as they don't start coughing or showing signs of respiratory distress, we can slowly advance the diet, okay? From clear liquid to full liquid to GI soft, okay? Also, just keep in mind that after an upper GI endoscopy, which is an EGD, a sore throat is common. Make sure you know that for NCLEX. They love to throw that in there so that you feel like, oh my gosh, something is wrong. A sore throat is common. And for that, they have lozenges, like kind of like cough drops, but just make sure their gag reflex has returned. And also sprays, like the chloroseptic spray you get when you have a sore throat, they have that. Okay, so your number one priority pretty much, so write this down. Number one priority for EGD is keep them NPO before and airway, before and after. Your number one priority is airway. Airway, airway, airway. And how do we protect their airway? We keep them NPO before, and after we keep them NPO until their gag reflex returns. So let's look at some pictures. So this is, a representation of an upper GI endoscopy. So this is the endoscope. As you can see, the healthcare provider is in full control of it. The patient is under conscious sedation. So they're not going to remember this. They're not under any pain, okay? But if you, conscious sedation, it's like if you told him like blink his eyes, he would blink. Or move your arm, he would move it, okay? And as the nurse, you would be there to assist the healthcare provider and pass them whatever instruments they needed. But this would be in the endoscopy center. So most hospitals have an endoscopy center that does this. So you would receive the right training if you were to ever want to do this. Okay? So for NCLEX, really, you have to know how to prepare the patient for endoscopy and what to look for and how to care for them after. Okay? So upper endoscopy, they're going through the mouth, down the esophagus, into the stomach, and they're going to enter the first part of the small intestine, which we can't see here because it's behind the transverse colon. Okay? And they can take pictures, they can stop upper GI bleeds, they can obtain tissue samples. For example, if the patient has been having difficulty swallowing and they believe that there's some type of stricture or constriction of the esophagus, and they find that there's a polyp or a tumor or Barrett's esophagus, they can obtain tissue samples via biopsy. All right. Next up is colonoscopy, or sometimes they call it a fiber optic colonoscopy. So a camera is inserted through the anus and rectum to examine the large intestine. Tissue samples for biopsies can be taken, and polypectomies can be removed. So again, it's the same thing. They're going there to observe what's going on. If the patient has a lower GI bleed, they can stop, they can identify the bleed and perform the proper interventions to try or attempt to stop the bleed. They can get tissue samples. If the patient has like a polyp in their colon, they can remove it. They can view or assess if the patient has diverticula, which we're going to learn about. Um, and what it's called when they have a lower GI bleed and they try to stop the bleed is they're basically going to burn it. They're going to burn that area to, that those vessels that are bleeding out, and that's called cauterizing those vessels. So nursing considerations and interventions. Well, first let me show you a picture. So this is a representation of a colonoscopy. So as you can see, they go in through the anus, through the rectum, and they're going to go through the colon to see what they need to see and intervene how they need to intervene. So nursing considerations and interventions, this is invasive. So when something is invasive, you need informed consent. Bowel prep so the healthcare provider can see the bowels. The big thing with a colonoscopy is if remember the colon is usually has poop in it. And how can the healthcare provider properly visualize the colon if there's poop in the walls and everywhere? So before a patient has a colonoscopy, unless it's like an absolute emergency, we're going to have to give the patient something called bowel prep. Bowel prep is essential so the healthcare provider can see the bowels because if something is there like a polyp or a tumor and there's poop on the walls, the healthcare provider can't see it. So bowel prep usually consists of some type of enema or magnesium citrate or something called Go Lightly. And Go Lightly is this big, huge plastic jug. I mean, it's much bigger. Think of like 3 gallons almost sometimes. And it has powder in it, and it's going to tell you how much water to put in, and you're going to shake it really well. And the powder is going to dissolve, and the patient has to drink the whole thing. It's usually nasty. It's very unpleasant. Doing bowel prep for the patient is very unpleasant for the patient. It's not fun. It's not easy. There's no patient that's going to say, oh my gosh, this tastes delicious and I want to drink the whole thing. No, they're going to say, oh my gosh, it's too much. It tastes disgusting. It's me. I'm going to throw up. But you tell them, look, you need the colonoscopy. And in order for the surgeon to see, or in order for the endoscopist to see your bowels well, you have to drink this because if you don't drink the whole thing and they send you to the test, they're going to send you back and you have to drink again. So tell them to get it over with the first time would be easier for them so they don't have to go through it 1.5 times, right? And drinking it, the patient is going to start getting diarrhea. That's the whole point, is to clear out their bowels. And so with the diarrhea, they're going to be like, oh my gosh, I can't drink it again. And just keep telling them that they want to get this over with the first time. So the preps are going to cause diarrhea to clean out the intestines. And just keep in mind that bowel prep does put the patient at risk for dehydration, electrolyte imbalance, acid base imbalance, and falls. Because remember, you're basically giving them like laxatives, like to make them go poop. So let's take a look and see what happens when we have good bowel prep and bad bowel prep. So the first picture, this is excellent bowel prep. I mean, that endoscopist, that healthcare provider can clearly visualize if there was a polyp, if there was a tumor, greater than 90% of the mucosa or tissue can be seen. Okay, if there is stool, it's mostly liquid. And if there's stool, like liquid stool, part of the apparatus or tools of the healthcare provider's equipment during the colonoscopy is they can suction. So excellent prep is it's just liquid stool, and they just have to do a little bit of suctioning for adequate visualization. Then the next one, we have good prep. It's more than 90% of the mucosa can be seen. It's still just mostly liquid stool, but the surgeon or the healthcare provider has to do significant suctioning. Then we have fair prep, where we have semi-solid stool. So as you can see, the walls are covered, so they can't really see everything. So they have to, when it's liquid stool, they can suction it, right? But the more suctioning they have to do, the more time the procedure takes, right? And everything in healthcare should be as safe and effective. So effective is getting in, doing it right, seeing what's the problem, fixing it, and getting the patient back to normal. But here, there's going to be a lot of time spent suctioning the liquid stool. And if it's solid or semi-solid stool, the surgeon, I keep saying surgeon, I mean to say the endoscopist or healthcare provider, for semi-solid or solid stool, they have to do like washing. They have also an apparatus where it will like spray water, and it will spray it so that it can be suctioned or washed out. And then the last picture, this is poor prep. I mean, they can't see anything. So if there was something wrong, if there's a tumor, if there's a polyp, they're just going to be struggling through inches, inch after inch after inch after inch, to get through the entire colon, and it's just not effective. So they're probably going to have to send the patient back. Like, let's say the patient only wanted to drink half of the bowel prep, right? Now the patient's going to go back and say, I'm sorry, now you got to do it again. So that's why I say it's better to do it one time than 1.5 times. Okay. And also, how you know bowel prep, like the patient's ready, is when they're just pooping out straight water. When it's just straight water, you know those bowels are clean. And then we keep them NPO before the procedure so the bowels stay clean. All right, guys. So today's session is going to be cut short. Again, I do have an appointment to go to. December is a little rough for me, but I promise you that after the holidays, things will get back to normal. But either way, we're still going to be meeting, and we're still going to keep going through. And I'm just going to keep making sure that I'm showing you what you need to know to pass the NCLEX. So don't worry about that. The quality of the review and information you're going to be getting is still going to be there. I just have to maneuver around a lot of holiday appointments that I cannot cancel. However, you all are still a priority to me. That's why I don't cancel class unless it's an actual holiday or a time where I feel it would benefit you to spend with your family. So for homework, I want you to read pages 220 to 232 in your study guide so that you can be prepared for next lecture. 220 to 232, okay? So next lecture, we're going to have a full class, and we're going to do questions together. So please read all of GI in your study guide so you can come back prepared, and we're going to go through the different procedures and diseases and essential GI medications and do questions together. All right, everyone. Thank you again for a wonderful session. Remember, you can do it, you will make it, and you will not fail. God bless you, and please take care of yourself. I will see you next week. Thank you so much.